Hello, everyone, and welcome once again to our anchor session of CME Palooza Fall. I am Scott Kober, one of the co-producers of CME Palooza. I believe Derek Warnick will be joining us at the end of this session as we wrap up CME Palooza Fall. I am thrilled to be helping with this final session of the day. This is a topic that was actually suggested to us by one of our viewers in the spring. So when we talk about the survey at the end of the session, believe me, we do listen to you guys, and we definitely take your feedback into account when planning some of these sessions. So this session is called Grand Rounds in the 21st Century, Fixing the Historical Model. And the session is being sponsored by Paradigm Medical Communications. This session is being moderated by Annette Donawa. I got it right this time.
Yeah.
And Annette is the Assistant Dean for Continuing Medical Education at Johns Hopkins School of Medicine. So a few housekeeping slides before we begin. First of all, I would like to thank all of our sponsors, our gold sponsors, Genentech and Platform Q Health Education. Our silver sponsors, CTI Meeting Technology, Educational Measures, iMedics, MedPage Today, and Paradigm Medical Communications. And our bronze sponsors, ASIM, Clinical Care Options, CMEology, Forefront Collaborative, Global Academy for Medical Education, Highmark CE, PVI, Real CME, Thistle Editorial, and Vindigo Medical Education. If you have not already done so, please, I encourage you to go to our sponsor tab to learn more about all of these companies that have sponsored our fall event. So there are 3 ways to ask questions during this session, and we certainly encourage as many people to ask questions as possible. You can use the MedPage Today text line to send in a question. The number is 267-6660-CME. You can also click on the Google Plus question answer link located at the bottom of each video. And you can submit a question through the Google Hangout platform. You could also tweet your question to us using the CME Palooza hashtag. So we'll be keeping an eye on all 3 of those areas. So hopefully we have a lot of people asking a lot of interesting questions of our panel today. And so with that, I'm going to turn it over to Annette to introduce the rest of our panel and to get us going.
Thanks, Scott. So I have 2 esteemed colleagues with us today. Timothy Peters is the director of the Office of CME at USF. And then we have Josh Sneed, who is in program development at Oakstone Publishing. Thank you, gentlemen, for joining us.
Thank you. Happy to be here.
Okay. So I think we're ready for the next slide. So these are the key themes that we're going to focus on during our 1-hour session today. We will explore the history of Grand Rounds. We'll look at 2 models of learning in CME, and our focus is really to move learning from a passive to an active engagement. We're also going to discuss how new models of learning can align quality improvement with CME activities. So just to give you a little bit of history about Grand Rounds, the tradition of medical Grand Rounds at Johns Hopkins can be traced back to William Osler, who was the first professor of medicine here at Johns Hopkins, beginning in 1889. So legend has it that the term Grand Rounds or making rounds originated when physicians had to climb a winding staircase that exited each floor into the circular hallway under the Hopkins Dome. So if you're looking at your slides, that picture would be on the upper right side where you see that winding staircase. So regardless, though, the purpose of Grand Rounds has always been to focus on patients and specific clinical problems. So with the next slide, we understand in CME that we have to embrace change even if we don't want to. So we've made concerted efforts to remove perceived commercial biases from our activities, our CME activities, and as a result, sometimes we have decreased funding from commercial supporters. But if you think about Grand Rounds, by and large, they're still rooted in an older tradition and an older setting. So now I'd like to turn it over to Josh, who will continue our conversation about change.
Hi. Thanks, Annette. So we think learning should stay progressive, and you can utilize new technologies without sacrificing content or participation. In fact, a lot of those who choose to incorporate new technologies into their learning are finding new ways and new opportunities to engage learners. We feel like with technology that live streaming, you don't even have to be in the same room to learn in real time like we're doing now. And technology allows an individualized approach to learning where one can move through the subject matter at a self-determined pace, and if you're doing it right, it boosts engagement, which is really what's the most important. So raising your hand in the back of the auditorium isn't the only way to interact and communicate anymore. Facebook has pretty much changed the way we communicate with each other, and not just personally but professionally as well. Medical professionals from all generations now are turning to online options for CME and education. A doctor can now use social media, connect, interact, and learn from doctors all over the world. I was just reading yesterday in the Journal of the American Medical Association that for all of Haiti, there's one full-time neurologist. 10 million people and one full-time neurologist. And he relies heavily on Skype and email and Dropbox to get second opinions from teams all over the world. And they also help with diagnosis. And these are patients that otherwise would go without treatment. So he relies very heavily on these things. And, they have volunteers that come in and out, but he's the one full-time guy there in Haiti. So I'd be interested to hear if anybody else has a situation like that where, a rural doctor can't really get away for a week at a time all the time to go to a conference and, these people aren't, they're not going to give up their vacations. We know that. So it's huge for them, and because we all know it's not always possible to get away. So we know change is coming, and meaningful change requires new thinking and new tools. We have to value a doctor's time, and if you want to hear how valuable their time is, you could probably just ask one. I'm sure they'd be happy to tell you. But we think that didactic learning can be done alone ahead of time, and we can let the time that they meet together be spent working through problems together. There are so many universities now that use this flipped classroom approach, and it's working very well, and there's really no reason why it couldn't work for doctors as well. So it's time to change the way we educate doctors, and I'm going to turn it back over to Annette now, and she can tell you a little bit about changing the way we go about grand rounds.
Thanks, Josh. So in the next slide, you'll see some core components there. And these core components really are rooted in the Bloom's taxonomy model. So with core components of any learning, there's knowledge, comprehension, application, analysis, synthesis, and evaluation. So these are core components that we really do need to integrate into the grand rounds educational instruction. So in the next slide, we are talking about andragogy. So for those of you who are familiar with the term pedagogy, pedagogy refers to young learners. And so Malcolm Knowles created the term andragogy to address adult learners. So here are some assumptions that we know about adult learners. Adult learners really need to focus on the relevance or the importance of the instruction. So instruction and education should be connected to personal experiences for the adult learners. We like to be self-motivated, and we like to drive our own learning experience. Each adult learner has different expectations. So the idea that one size fits all actually is not a good assumption, because one size does not fit all. And then most adults have developed their skills that focus on problem-based and task task-based learning. So when you have case studies involved in the learning education, those are very helpful because as adult learners, we really do like to focus on problem-based solutions. So what's the ultimate goal? The ultimate goal for CME is to move beyond issuing certificates. And as I'm looking at my slide set, I see that I need to turn it over to Tim Peters. So Tim, you probably want to go ahead and pick up where I left off.
Sure, thanks, Annette. Well, I was going to mention, the assumptions you named in the previous slide are really important because understanding them is important to the goal of moving CME as a credit gatekeeper out of the basement and into the middle of relevant, appropriate interventions that address real needs, that are relevant and self-directed and motivating. So one method was the AE4Q program, which is described in the article from which this quote was comes from. And it made us ask ourselves as well, how else could we reach this goal? And what we had come up with is that there are two really important models of learning that may or may not be tried in grand rounds type situations. And they are problem-based learning, which has at its core coaching and multidisciplinary team-based exercises that focus on real problems, and the flipped classroom, which Josh alluded to earlier, where learners get up to snuff on an actual problem before they attend a live or virtual discussion on the topic at hand. And the reason for looking at these two especially is because relevance and practicality are everything. So individualization, self-direction, all the things that Annette just described really are important to keeping it real for the adult learner. With that, I think first we'll maybe look at an example of problem-based learning that we'd come up with, and certainly we've had some experience with this at UCSF, but I'm by no means an expert in this, so I have to enthusiastically thank one of our colleagues for digging up some of Spencer and Jordan's work on learner-centered educational approaches and putting this slide together. So this is the Maastricht 7-jump sequence for problem-based learning, and it's very much focused on small groups engaged in deeper learning with a mentor or a facilitator. And this doesn't exactly describe your average case conference, but it definitely looks more like a shared problem-solving session, maybe along the lines of a tumor board in some hospitals. So I'm hoping UCSF's experience with PBL in a rounds-type activity will inspire new ways to think about these types of activities in your own programs as well. So a little background. About nearly 2 decades ago, Dr. Lucius Summers, one of our family medicine professors at UCSF, recognized that clinical uncertainty was endemic to primary care clinicians' work, and that there was a lack of a practice-based collegial forum to address it. So within her own practice and with others with which she interacted, she explored the question, what would happen if, once out of training in their workplace settings, primary care clinicians had time purposely set aside to meet with their peers in facilitated small groups and discuss patients that stumped them or caused them worry, or for whom what they were doing just was not working. And so this exploration led her to look at problem-based learning techniques to build what she called a practice inquiry colleague group. And the group was established to build that collaborative engagement. It consisted of an interdisciplinary audience, primarily in this case physicians, nurse practitioners, and physician assistants. And each was asked to come and present a patient case where uncertainty existed from their own patient panels, and then collaborate as a group to solve them or define potential next steps to relieve some self-doubt or really progress a patient's treatment forward. So the groups met regularly at times that were sacred on the calendar, so there was no excuse for not showing up, like you were expected to be there. Over time, what happened is that there was no need for those excuses. People were intrinsically motivated to go, that they found real value in the discussion and in the facilitated small group that happened. And at a 10,000-foot level, Basically, each group focuses on a single difficult patient case, where the clinician might be experiencing self-doubt or is just absolutely stumped as to what to do next. And the case is presented through a structured interview. So the facilitator asks about the problem, what are you running into? And the clinician, or in this case the presenter, describes what's not working. And then the facilitator keeps prodding with very specific questions in this technique, running through that 7-jump sequence, and to help get a better understanding for the cause of the problem. The group chimes in, they get to ask their own questions, and from their own viewpoints, and especially within their own patient care. And then the facilitator guides the group to synthesize all the explanations, look at the varying viewpoints and experiences, with the hope of alleviating the uncertainty about how to proceed. So why it's important is that through this process, the clinician engages actively and outright with the uncertainty. It's hard to have self-doubt and ask for help, and this process kind of forces that to happen. And they can begin to seek solutions effectively to work with the patient. But in addition, each participant in the group is prompted to reflect on his or her own patient panels in light of the case under discussion, and to think about their own strengths and weaknesses in relation to their own patients. So not only is the topic relevant to the target audience, but each clinician has had time to learn and analyze and reflect and synthesize solutions to their own uncertainties in their own ways. And this really creates some deeper learning for the group at large. CME got involved with this project about 10 years ago. There's 13 groups that run each year in practices at UCSF and at Kaiser, and in clinical community clinics around the San Francisco Bay Area. It's inspired some other models. For example, in our Division of Hospital Medicine, they have a rounds that we call Cases and Conundrums, which is exactly that. So everyone, this interdisciplinary team, is asked to bring in their puzzles and work as a group to solve them. And so it's just really created a shared learning environment. So with that said, some of the benefits of problem-based learning become very apparent. So the model creates a more optimal learning environment. The learning experience is individualized. It harnesses the group's experience. It motivates learners in the context of real-life situations. What else did you say in that? Yeah, so I think it really picks up into a lot of these things that where andragogy has become important to the adult learner, and in moving learning from passive to active. So a little bit like case-based rounds, but not quite, because it tends to be much more interactive and not my best friend's in town and he gives a great talk. And people are really intrinsically motivated to attend. So I think the last thing I'll add to that is that in the slide deck that we distributed beforehand were some suggested readings, and I learned a lot from those. And so if you're interested in exploring more, I would definitely look at those, including Dr. Summers' recent book on clinical uncertainty and her practice inquiry on that. So with that, I will drink some water. Thank you.
We have several questions that have come in. One is dealing with the flipped classroom model, which I see that your guys are going to get to next, so I'm going to hold on to that one. But let me ask you a couple of questions that have come in. So this is a question that came through the Google Hangout panel. So who do you think is best to execute CME Grand Rounds, the institution or a third party, for instance, a medical education company?
I have an opinion on that.
Go ahead.
I would say the institution is in the best position. And the reason being is that there's such an opportunity to engage a very specific audience in a very specific problem within the institution. There's room for the quality folks to be involved, to show where there are gaps in practice that need to be looked at. And rounds planned and controlled by the institution can then guide those discussions to reach solutions to those problems.
And I actually can agree with Tim. I know with many of our departments here at Hopkins, we collect surveys. And so based on the survey comments, the evaluation comments, programs are developed based on those comments, like a little needs assessment. So I think that the institution is probably in a better position to understand what the clinicians' needs are and where the gaps are.
I agree,
Okay,
and
so
that coming
that leaves a
from
little bit of. Go ahead, Josh. Go
I
ahead,
would
Josh.
just
Sorry.
say, coming from a medical education company, I wouldn't feel comfortable coming in and telling someone like Annette, like, listen, this is really how you should be doing these grand rounds. And so I agree with both of them that it, just for a collaborative effort, really, it probably better to do from the institution. I would agree.
Okay, so here's another interesting question. So with the variation in specialties among healthcare providers that may attend grand rounds and their differing roles in patient care, how do you have to perhaps adjust your expectations with the collection and interpretation of outcomes data based upon these differing roles of your potential audience?
That's a loaded question. Tim, you want to take a stab at it?
So let me ask you this: do you guys, try to collect outcomes-related data from your grand rounds, or is it something that you say grand rounds are just not are just not intended to be, the agents that are going to drive, change in knowledge, competence, and performance?
I would say that ground rounds does have the opportunity to drive that change if they're structured correctly. UCSF, we do collect outcomes data. I have to say most of it is competence at best. For those that are actually engaged in quality improvement projects throughout the year, or a QI project throughout the year, we do see some outcomes data from that, but it's hard to get a hold of where QI keeps us kind of siloed for now.
Okay. Okay, Annette, I'll hold on to a few of the other questions until later if you want to jump back and maybe talk a little about, I don't know which one of you is talking about the flipped classroom, but I know that that's sort of the next up on your slides.
Yes. So I have a note here that Josh and I will talk about this, and Tim, of course, if you want to chime in, please do so. So many of you may know that we attempted to explore the flipped classroom approach with this presentation. So we posted some suggested readings, and we also posted our slide set so that learners or participants will have an opportunity to review the slide set and actually prepare great questions for us. So I can tell you that in SACME, which is the Society for Academic CME, as the program chair, we are definitely exploring this approach and this model for the fall conference. And so I'm going to give a little blurb about SACME. Our conference is on November 13th. It's on a Friday here in Baltimore, so it's convenient for regional folks. And two of the presentations in particular are exploring the flipped classroom approach. So Dr. Todd Dorman will give a talk on education across the curriculum or the continuum, and he is going to address LCME, ACGME guidelines in addition with ACCME. Dr. Sean Barinholtz, who is a quality expert here at Hopkins, we are actually asking folks to get up out of their office and go and talk to some quality folks at their institutions. We want them to ask questions to the quality folks. For example, what high-level quality initiatives are you working on? How can CME, CPD be involved or get involved in those quality initiatives? And then what quality metrics are going to be used? So that information should be posted on the SACME website by tomorrow. So please go to the SACME website, take a look, and we hope that we can generate more interest, and we want the learners to come to the conference prepared to discuss their findings and what they've learned. Josh?
Oh, no, please, go ahead. Go ahead.
Oh,
I'll let you get through the slides, and then I'll jump in whenever I can.
okay, so I'm actually finished with my talk about the flipped classroom. I just want to say that I think it's a great approach, and the focus there is to have learners do pre-work prior to showing up in the classroom environment. So with grand rounds, we think this would be a great model to try, a great approach, because you want people to come having done some some background work, some homework. You want them to come to the learning environment ready to ask questions, and the focus is on application, applying those concepts that they have read about.
So Annette, this is a question that came in that sort of applies to what you're talking about. So for a flipped classroom model, do you go beyond providing reading and resources to actually doing testing or some sort of active participation of the learner group in order to assess, how to perhaps best spend your time in the classroom so that you can actually get some feedback from them in advance to kind of figure out what they need to learn about? And along with kind of having them preparing, for the session themselves?
So I think that with the flipped classroom approach, I think that people can be very creative using this model. So those were some great examples and great suggestions that were integrated into the question, Scott. And I'm very excited that people are listening and ready to participate. But I would say yes. Flipped classroom approach definitely should go beyond suggestive readings. We should, again, get people to be actively involved, engaged, and get them having conversations with other colleagues prior to showing up to the learning environment. And as I've said before, I think this would be a great model for the Grand Rounds clinicians to try out and to test. So definitely should go beyond the suggestive readings, and I think people can be very creative in the approaches that they try.
Okay, great.
So with the next slide, we tried to integrate some comedy in our slides. So again, we talked about flipped classrooms and grand rounds, and the focus is to really bring that patient closer to the physician. Okay. So I think this is my slide and Tim's slide, but here are some benefits for a flipped classroom. We think that the instruction and education can be more efficient. Learners, again, can be prepared to come to the learning environment asking very specific questions, and again trying to apply those concepts to the learning environment. The focus is definitely on students, and I think that with the flipped classroom, the interaction between the students and the teachers should definitely increase. And then students can assume the responsibility for their own learning. We talked about Malcolm Knowles' andragogical approach, and learners, adult learners, really do want to take control over their own learning experiences. Tim, do you have anything else to add?
No, I was going to tie it back to the motivation. So, we don't have a lot of experience with flipped classrooms here, although we've had several similar types of activities that happened before they called it flipped classrooms that were very similar. And that included doing a short self-assessment for a live CME meeting with 300 people. And the response rate was incredible. People were really excited to find out where they were. The faculty were less excited because when all the results came in, they had to tweak all their talks on the fly to really work with the audience. And we even had to break the audience up because they were in some different levels. But it was really fun, at least from a CME coordinator's point of view, way back in the days. And it was really effective. People were very excited. But I wanted to add to that, my son goes to a performing arts school, and most of his classes are flipped. So he is responsible for finding all of his resources, reading the history book, looking at videos, watching movies, talking to his friends, whatever it takes, so that when he shows up in class the next day, they are able to say, reenact the French Revolutionary War, and based on the facts that they should have already learned. And he cannot stop talking about it. I mean, he's obviously an impressionable teenager, but just it's amazing, and I'm excited for his learning, and I'm excited to go to his school, and I'm like way beyond that. But I think that adult learners would fall into the same excitement.
And thanks, Tim. And I think the key there is to really make the learning relevant. Adult learners, again, they have to connect this education to their personal experiences. And I do think including or incorporating a flipped classroom approach probably will spruce up the grand rounds. So I think Scott has another question for us.
Yeah, so you guys are sort of dancing around this topic, but this was a question that came in over Twitter, so it kind of asks more, gets at it more directly. Are we sure the flipped classroom model is effective for CME? It is routinely tried at industry meetings, and no one reviews the pre-reading. So is it just the buzzword of today that is going to be replaced in 2 or 3 years with a different model because it just doesn't stick?
Yeah, it's a very good question. I mean, I'm headed to SACME here in a couple of weeks, and I'm like, wait, we have homework?
Yes, you do.
So, I think there needs to be a little more gravitas behind it, perhaps. To say, here's some pre-readings, like, oh, here are the slides, kind of review some stuff before you come so we don't have to spend a lot of time going through them, is a lot different than saying, learn this, because when you get in this classroom, you are going to do this and this and this. I think maybe if instructors are more specific about what they're expecting the outcome to be or what they're expecting the learner to do, that they could take it more seriously. But it's a very good question. I mean, it could just be another, our buzzword of the week.
Yeah, because I think from my perspective, the challenge is always, let's say you have 20 people coming to the meeting. Well, let's say only 10 people do the pre-reading. Do you cut off the 10 people who haven't done the homework, who haven't done any of the work, and say, well, you're not going to get anything out of this session because we're starting at point C and you're at point A? Right. So I think it's a difficult conundrum when you're. I mean, it's one of those things that sounds great in theory, but I think there's got to be some more thought into exactly how to implement it.
Yeah, I think everybody has to buy into it for it to be successful, for sure.
Yeah, and then I guess the question, how do you get everyone to buy into it? Right. So, okay.
So I didn't tell the participants that we have a surprise for them. So I'm glad that we were last, Scott, on the agenda for today, but we do have a surprise from Josh. Josh is going to show us a demonstration of a web-based platform that his company has used, and I think this will be another unique way of allowing people to learn in a different environment.
Okay, thanks, Annette. I'm just going to take a second here to share my screen. Okay. Hopefully you can all see the demo that I have pulled up here. So basically, we've talked a lot about being able to kind of control the pace of the learning yourself, and also to engage the learner. And hopefully that's what this demo does. It kind of shows you basically that you're even progressing the slides yourself. Normally with a didactic lecture, even if you're watching it online, you hit play and the information is thrown at you and you kind of keep notes and then you walk away at the end. Well, even with this demo here, you're progressing the slides yourself and you're literally learning at your own pace. So right away you'll see you have engaging images. You'll have audio, video. I know you can't hear this, but I just wanted you to be able to see it. you're kind of getting expert input on the topic. Then you can kind of go up here, and instead of cluttering a slide like you would normally get with information everywhere, you just sort of choose what you want to look at, bring it up, take any notes you want, get rid of it, go on to the next asset, and you kind of have it. It's a more organized approach, and you can kind of learn at your own pace, as we said before. And then for any further reading, there's a link up here to that where you cite your sources and redirect anyone who wants to go somewhere. Again, it's more the same, where you have your audio video aspect here to give you a better idea. And you can stop it and start it at your own. And then let's say it was if you would imagine a case-based approach to something like this, where you would have your case laid out here and the possible treatments below. Select a treatment, and you can kind of follow through the case to see where the outcome goes should you choose that treatment. And of course, you have a multiple choice, so one's right and the rest are somewhat wrong, I guess. And it would just sort of take you through that whole process, and at the end you would have another aspect, an audio-visual aspect here, that would where an expert would come in and give you 10 to 15 minutes on the topic. Then at the end of let's see here. So then at the end of the section, you would basically have a question which kind of gauges the comprehension level of the learner. And they're very low stakes questions, nothing that's going to be posted anywhere by any means, but just to make sure you're paying attention, keep you engaged, and to kind of gauge your comprehension there. So that's just a short, quick demo to show you guys, and I'll turn it back over to you, Scott.
So Josh, was that something that was used as a flipped classroom program to kind of prepare learners for a specific grand rounds?
So this is something we'd like to see implemented in grand rounds, but it's something we're now producing for just normal. We're converting didactic lectures into this enhanced CME approach to getting our programs out. Some of our programs are anywhere from 10 hours to 127 hours, and when you get into just 127 hours of didactic lectures, it numbs your brain pretty much. So it's a way to sort of keep the learner engaged and really interested.
Okay.
And also perhaps to help bring those at point A up to point C. A small self-assessment before a flipped classroom, or before a flipped class situation, could help people assess where they are. Formatively think about, all right, I do need to kind of run through this case and see what the basics are. So when they show up, at least in a grand rounds, the discussion could be meaningful and relevant for them as well.
Okay.
The thought.
Absolutely.
Okay. And now, Josh, was this something that you guys built using your own proprietary platform?
Yes. This is something that we designed and built in-house here.
Okay.
So with Josh's demonstration, I think the participants can see that the learning is definitely individualized, because the learners can click on particular buttons or segments, and they're in more control over their learning, and they can use their own pace to learn. So I think a benefit to a program such as this, using a platform such as this, is that learning can take place at any time. As Tim mentioned, it could be the pre-learning to get ready for a grand rounds didactic lecture, or it could happen after the lecture. Oh, now I want to get more information and do further study about this particular problem or concept. So I think with this platform, the learning can definitely be a little bit more creative and flexible and adaptable to that adult learner. So at this time, I think we are ready for Tim to jump back in our presentation. Tim.
I think this the last thing we were going to look at was maybe another example of problem-based learning that was that had come out of the article from the AAMC reporter on the AE4Q project. And I believe it was the University of Kansas Medical Center had instituted some of the tenets from the AE4Q to identify and solve a problem that they had there in the medical center. It was focused around VTE. I believe there's a slide here toward the end that summarizes that case. Dr. Pingleton is probably far better at explaining it, but this is a case where really they got a group. They saw that there was a quality problem with VTE in the hospital, and a group of the clinicians got together and looking at the various causes of why, what the issue might be, and they had hundreds of people interact with this over time. And what came out of that was an educational plan to intervene to solve this quality problem. And it included some didactic lectures and was paired with what we like to call in CME the non-educational intervention. They wore little badges looking for signs of VTE, reminders about how they would approach their risk assessment, those kinds of things. And what they found that through kind of iterative sessions like this, that by the end of the period that they were measuring, that their incidence of VTE had fallen about 35%. And this is a really nice, easy, concise success story of how engaging a group in solving a problem relevant to their practice and keeping them motivated to work on it can really lead to change that is measurable from a patient perspective, especially. That's what I got.
Thanks, Tim. And I don't know if the correct slide is up on the screen, but the title of the slide is a PBL Success Story. So that is the slide that Tim was referencing. So Tim, thank you for giving us that example, and thank you for walking us through some of those details. So we are actually at the end of our presentation. We wanted to end on this slide just to emphasize that change is imperative. It's critical for us to change how we conduct the grand rounds, and it really is time for us to move forward. Why not embrace technology? Why not embrace new learning models such as the flipped classroom approach? So we definitely want to open up our lines to questions. We've been getting some questions throughout the hour, so I'd like to open it up for questions. And while we're waiting for more questions, oh, I think we have a question.
Yeah. So I think you've probably talked a little bit about this, but I wanted to get to it just so we're addressing it. So this was routed to you specifically, Annette. Can you please link the measurement and technology standards for CME of the future to the needs of updating grand rounds as you are discussing here today?
So I think in order for me to do that, I would have to do a little bit of research, so I can't do it right now live. But I will say that there is definitely a direct link to metrics, quality metrics, to grand rounds. And as an instructional designer, I would say that the starting point is really to conduct a needs assessment and needs analysis. I think that in one of the slides we said for adult learners that one size is not going to fit all. And I think that's certainly the case here, Scott. In fact, one of my closing comments would have been, we are trying to get people to change how they do grand rounds. But, the traditional approach might still work for some learners. And so we have to keep that in mind. We have to look at, generational gaps and look at the learners in specific. So I'm not suggesting that the traditional grand rounds does not still offer value, but I do think that we do need to conduct more needs assessments and look at how we can embrace changes, embrace improvements, and really look at the learners of today.
I think it's always interesting how some of our sessions tie together. So there was a session earlier today about the generational differences amongst our the physicians of today and the physicians of the future. And as you say, at least my experience with Grand Rounds is that it is a lot of the older physicians who will show up. I've seen a lot of retired physicians who will be the ones that will come, still liking sort of that old didactic format, whereas the younger physicians weren't necessarily as engaged or as likely to show up at 7:30 on a Wednesday morning for a non-required CME certified Grand Rounds.
Thank you, Scott, for that information and comment. I would also say that I've done some research in critical thinking, and there is value for discussion and debate. And I think in the traditional Grand Round setting, those physicians can have open, honest conversations. And so there is value in having those in-person meetings, having discussions, and of course, having debates.
Okay. There are a lot of people with comments and questions about the flipped classroom model coming in. People on Twitter, people on our MedPage Today text line, people on just the Q&A. So, and I think you talked a little about this. How many Grand Rounds activities have you guys actually had an experience with that have adopted this model? And I think you kind of said you've sort of piloted a little bit, but it's just kind of an idea more so than something that you guys have really implemented to any large scale. Is that right?
That would be correct in our setting. I can tell you that we have one coordinator who coordinates about 80 Grand Rounds, and she is overworked, and we appreciate the work that she does. But for us, it's really an idea, a concept right now, where we're trying to integrate this new learning model. But Tim, I think Tim has more, immediate experience with trying to integrate this model.
Well, actually, not necessarily in Grand Rounds. Again, like we have 70 series as well throughout the year, and most of them are coordinated by individual coordinators in our departments. So this is a bit of a sea change in that respect, right? I mean, I would have to pretty much walk the halls and convince my faculty that this is the way to go, and it's just a little bit of extra work. If they would throw it in, it would be worth it. And we haven't gotten quite that far with getting it implemented. Certainly not as far as making people think more critically about what they're doing and using problem-based learning or specific practice techniques. So.
Okay, here's another question that came in on our MedPage Today text line. Do you use social media for engagement in your Grand Rounds? And if so, what channels have worked best for you?
Tim, do you want to take a stab at that first?
Sure. Twitter has worked best. It seems to people feel comfortable tweeting conferences, for example, and it also seems to work with the residents and some of the more junior faculty. Some of our rounds require that they text in their attendance, so they've already got their phone out, they're already interacting with it, and they will tweet their colleagues who are unable to attend the rounds with little pearls of wisdom. But yeah, I found that to be the most useful, and we only see it in about 30% of the rounds that are happening.
And I can tell you that here at Hopkins, we use social media to promote our live programs. But with the Grand Rounds, if you think about the traditional approach, departments will have meetings about once a week. And I think that their program is online. I don't think that we have embraced social media with the Grand Rounds, but that is certainly something we can move forward and try.
Okay.
There's some generational divide there as well, I'm sure.
Yeah, definitely.
Well, that's the last of the questions that I have. I don't know if you guys, if you want to have any closing comments on that, or if you just want me to bring Derek in to wrap up another year of CME Palooza Fall.
So I wanted to give Tim and Josh an opportunity to give some closing comments, and then I can close out our session, and
Great.
we'll be ready for Derek.
Okay.
Do we do this in alphabetical order?
However you want, Tim.
Yeah, well, I think, my closing comments would be that there's so much that can be done with grand rounds, but like any large institution, I think there still needs to be a lot of cultural change. So traditionally, they are seen as the talking head. There are community physicians who are involved. It's an easy way to get CME credit for the faculty within an academic medical center. But as we see some of its effectiveness wane, and I look at other departments looking to kind of reinvigorate it, and they're still thinking in old ways. They're like, well, maybe we'll just change the way we do the didactics rather than changing the entire structure of how the sessions work. And so I think we have to think about this in the context of making minor tweaks over time. Engaging one series at a time to make just some changes that are going to make grand rounds more relevant to its intended audience, and especially since they're so busy, and really get them remotivated to make it a more engaging learning experience. There's no way this is something that would change overnight, but chipping away a little bit at a time. Just trying some of the techniques discussed here and others that I'm sure there's some excellent ideas out there that you can make a small difference a little bit at a time. And, yeah.
Thanks, Tim. Josh?
Yeah, I agree really with Tim, and I think it's got to be small changes, one at a time, and slowly building up to the big change, because just hearing the two of you, 70 programs a year, 80 programs a year, it's hard to just turn that over with the flip of a switch. It's going to take one specialty at a time to really make a change, and a permanent change. But when we talk about new ways to engage learners and to enhance learning and bring people together, we've heard the word exciting a lot today or during our talk, and it is. So I would love to see the changes made eventually, even if it is one small step at a time.
Thanks, Josh. And of course, I agree with both of you. I think we have to remember the organizations that we work in. We work for academic medical institutions. And so we have several employees at our institutions, and change doesn't happen overnight, as Tim mentioned. But we can make small changes as we go along, and we can try to make changes and improvements to other aspects of our work. For example, society meetings. I mentioned SACME and how we are trying to explore the flipped classroom approach and get learners engaged prior to coming to the meeting. So I think that there are ways that we can try to make improvements and provide some changes to how things are done, but it will take some time. And I know, Scott, you mentioned in one of the questions, is the flipped classroom really a new approach? Haven't people been doing some sort of flipped classroom in the past? And I do agree with that. We as educators like to put labels on models and concepts. So I just wanted to thank our audience today. Some of you have been involved in most of the sessions throughout the day. This was the last session, so we really do appreciate you tuning in and listening to our concepts, our ideas, and I think that at most we can still try to make learning relevant to the adult learners and ensure that they are motivated and focus on what's in it for them. What are they going to get out of this learning experience? So thanks, everyone.
All right, so thank you to Annette and to Josh and to Tim and to all of our faculty from today. So one final push for if you have not yet completed the CME Palooza survey, it is available to access on the Live tab, a very short survey, but this is our best way of measuring who was watching, what sorts of things you liked, what sorts of things you didn't like, and we have a place on there for people to tell us a new joke. So I'm going to go into my son's pre-K classroom next week, so I'm looking for jokes for 4-year-olds. So if you have anything good, please let me know. And there is no next session, so we don't even have to worry about this slide. So I am going to bring Derek in and to kind of wrap up another CME Palooza. He always likes to have the last word, even if the last word is. So go ahead, Derek.
I don't got a whole lot.
Words of wisdom from Derek Warnick once again, people.
There you go. The archive is up for all the sessions. No thanks to Scott, who didn't do any of it. I did all of it myself. Thanks, Scott. Except for this session, which will get up quickly. So if you were unable to join us for the live part of the program, thanks to my hard work, you can now go and watch the archive. Other than that, thanks to everyone for all the faculty, everyone who participated. We had lots of questions today. That was great. I think this maybe was, what do you think, Scott, most ever that we got question-wise?
I think so. I think we did really well, and then they came in from all different avenues,
right,
which was always nice.
Yep, agreed. But other than that, thank you all. Anything for you?
We'll see you all in the spring.
That sounds perfect. All right.
All
Talk
right.
to you all later.
Bye.
Thanks. Bye.
Bye.